Most health system workforce planning is a lagging indicator exercise. You are staffing for yesterday's demand with yesterday's workforce model in a market that has fundamentally changed. Traditional healthcare workforce planning was built around stable assumptions, relatively predictable demand, a workforce pipeline that is tracked with enrollment data, and compensation models that had not faced a structural reset. All three of those assumptions are now wrong. Demand is volatile and shifting across settings. The workforce pipeline is constrained in a way that the training levels in the past can't resolve. And the compensation baseline reset during the pandemic has not returned to where it was. What most health systems are missing in workforce planning is the intersection of four things that have to be analyzed together. First is demand forecasting by setting and service line, not just overall volume, but where patients are going and what clinical competencies are required there. Second, supply modeling that accounts for attrition at the individual role level, not just aggregate. Third, care model evolution. What does the workforce need to look like in 3 years given telemedicine expansion, AI-assisted workflows, and scope of practice changes? Fourth, time to fill reality. Most workforce plans assume 90-day fills for critical roles that are running 6 months or longer in the current market. I've worked in health systems that were planning for workforce needs 12 months out based on historical attrition rates, while running 60-day vacancy rates that were already higher than their plan assumed. The plan was well built. The assumptions were wrong. The result was a staffing position that was worse than the plan had predicted and a response that was reactive rather than designed. Is your workforce plan built on pre-pandemic assumptions that have not been formally revisited? Drop your honest answer in the comments. If this is something you're trying to work around, feel free to reach out. I'm happy to help.